Kajala Medical presents COVID-19 The Answers, the show that delivers the scientific, evidence-based knowledge that can safely return us all to our pre-COVID lives. My name is Dr. Fumi Okanola, and I'll be hosting the show. Every week, you can listen to me interview a highly respected professional about the science that can reduce your risk of becoming infected with this coronavirus. I'd like to introduce Professor Amitava Banerjee. Professor Banerjee is a professor in clinical data science at University College London and a consultant cardiologist at University College London Hospitals and Barts Health NHS Trust in the UK. He is also adjunct associate professor in public health at Amrita Institute of Medical Sciences in Kochi, India. Professor Banerjee is the principal investigator of the UK Stimulate ICP project, involving the largest clinical study of long COVID to date that will be conducted over 2 years. Ami, welcome to COVID-19 The Answers. Would you like to tell the audience what led a professor in clinical data science and a consultant cardiologist to study long COVID?
Thanks very much, Fumi. As you said that question, that says really that a cardiologist has no business dealing in infectious diseases, and it speaks to how in healthcare we do tend to work in our specialties and in our silos. And actually, of course, whether it's physical and mental health, whether it's cardiology and infectious diseases, there are links. And for me, the link was that one of my patients in my heart failure clinic, that's the part of cardiology that I deal in most, asked me why in March 2020, he was being told that he was more at risk of getting severe COVID-19 and of dying from COVID-19. That was in the Chief Medical Officer's announcement in the UK about particular diseases where you should take extra precautions, think about shielding, staying at home to avoid infection. So that was how I got interested and started doing research in COVID.
Excellent. So, please note to the audience that the research papers referred to in this part of the programme will have links provided to them in the show notes. You have stated in a recent interview with the UK Guardian newspaper that throughout the pandemic, long COVID has been absent from government briefings and media reports. Funding and research have focused on acute effects such as infections, hospitalizations and deaths, but not chronic effects. Why do you think chronic effects of COVID have been excluded, and why is this an important mission?
Well, for me, this is not a new situation in that we, in emergencies such as the pandemic, we focus because of attention span, the media cycle, also because of resources and bandwidth on the acute, which in this case was at various stages in the pandemic, an overflowing of the ITU units in hospital, very high death rates from COVID. And so the acute burden was high. It has been a really big effect for individuals, for their families, for health professionals, but that meant we weren't thinking about the longer term consequences, whether it's in terms of what's the impact of having a large number of people in the population having an infection, what's the impact on their health in 12 months or more time, and what's the impact on the economy. And so I think we've seen before that chronic conditions tend to be a lower priority. They don't capture people's priorities, whether it's politicians or the general public, as much. In this case, it's important because it's what I call the long tail of the pandemic. You might think that the biggest burden to individuals and to health systems is that acute part, but actually, if there is a long-term consequence, which is what long COVID is, then the impact on those people's long-term health, physical and mental, the impact on the economy because they're off work, the impact on their families will far outweigh the acute impact. So this is something that we should all be opening our eyes to.
Very much. Modern medicine still seems to focus on the treatment of disease rather than its prevention. How do you think this is fed into the management of the pandemic?
Well, as we're talking, the UK has lifted its restrictions and any COVID legislation today. And that's prevention in terms of mask wearing, in terms of the possibility of having restrictions if infection rates rise. And the alternative is to allow high rates of hospital admission, ITU admission, and so on that may occur. And we've seen this, whether it's in terms of cardiovascular disease, in terms of certain other diseases such as cancers, where there are prevention activities that you could be doing, whether it's investing in programs that try to reduce certain behaviors like smoking or reducing alcohol consumption and more exercise, versus reducing the levels of certain risk factors such as cholesterol and so on? Or do we invest money in treating the effects of not managing those risk factors such as heart attacks? And in the same way, that's continued in the COVID era. The relevance here, I think, as well, is that there are underlying risk factors such as heart disease, hypertension, diabetes, where those people who have poorly managed risk factors do worse in terms of their outcomes in COVID as well. So prevention definitely is better than cure, is better than treatment in this case.
How do you think we can lead the medical profession towards a disease prevention approach? The government doesn't seem to be going along that route, but how do you think we can lead the medical profession that way?
Well, I think we need to lead the medical profession, but we also need to lead the population, the patients, because it's better to change hearts and minds of patients rather than change the hearts and minds of health professionals. And I think the problem for policymakers is that they think in short-term cycles, five years of their elected period. They're not really thinking of 10 or 20 or 30 years down the line. And the fact of the matter is that if you invest, and I'm talking about not just money, if you invest your time, your energy in prevention, then that will pay off in years, in decades, not just in the next 2 or 3 years. And that has an impact on both your physical and mental health. It also means that hopefully you avoid having to use healthcare as much. Nobody, in my experience, wants to be on more pills, wants to be on more tablets, wants to be having more treatment. So in order to get to that position where we're encouraging prevention, I think we need to be changing the dialogue so that people see that there is, over the longer term, a benefit to it.
Yeah, I think you brought up some incredibly good points there. I've always been frustrated as a healthcare professional about the fact that we don't really plan for health. I mean, I mostly grew up in the UK. We don't plan for health for a generation. We do need to plan over 30 years rather than the short political 4 to 5 year cycles that we do. So it would be really good if there could be some form of reform to do that, really. Moving on, so you have been involved in a large study that is focused on researching long COVID. Can you tell the audience what Stimulate ICP is and how it came to be set up, and what are its goals and objectives?
Stimulate ICP is a 2-year study funded by the UK's National Institute for Health Research in a specific funding call for long COVID research. It came about actually because we were listening to patients and health professionals, and I myself am both a practicing doctor as well as a researcher. And in my case, I was seeing people with cardiac complications in the long term from initial COVID infection, sometimes months later. And so we decided that we need to, as my colleague and co-lead of this study, Dr. Melissa Heitman, says, we have to build the plane while we're flying it. We have to do the research while we're seeing so many people with COVID and long COVID. The best way to avoid long COVID is to avoid getting infected in the first place. We should not have been in this situation. And if you look at the countries where there is a large burden of long COVID, it's the countries where we've had unmitigated infection. That's the US, that's the UK, and a few other countries around the world that they have the worst burdens of long COVID. And that's the case here. So we have to, at scale, both map out the trajectory of disease. By that I mean who recovers, how quickly do they recover, who needs more help to recover, who's at risk of having prolonged symptoms and organ impairment in the first place. Are the clinics that we've set up functioning in the most effective way? But the main part of our study is a trial where we're recruiting 4,500 people with long COVID who have been referred to the clinics in the UK, of which there are 90 now. We're focusing on 6 centres initially. That's Hull, Liverpool, Derby, Leicester, Exeter and London. So we've got a wide geographic spread, but also differences in the way the health system is set up, or the clinic is set up there. Some of those are in primary care, some of those are in hospitals, some of them are virtual, some of them are face-to-face, so that we come up with a solution that's scalable, because the Office for National Statistics has estimated there's 1.3 million people with long COVID today in the UK. That's as many as with any God-fearing long-term condition. So we need a quick solution and quick trials of treatment so that we can offer things that are evidence-based. So in our trial, we're looking at investigations, drugs, and also a digital enhanced rehabilitation platform as well. But we are one of several studies that's been funded. You know, our study is not going to have anywhere near all the answers. I'm glad that we're able to work in this space and hope to provide answers to patients. But you know, we can't do all of it in one study. Another area that we're looking at as well is the inequalities in access to services, whether that's by geography or ethnicity or age or gender. And also beyond the pandemic, given the scale of this challenge to our health system, we're hoping that by comparing with other long-term conditions, from depression to heart failure, we can think about how we can better treat chronic conditions at scale.
You brought up so many good points in the statement that you just made. I think I'm being presumptuous. It warrants a follow-up interview to see your findings on that very interesting research. So looking at a great paper you had published in the British Medical Journal, or BMJ, in March 2021, titled Post-COVID Syndrome in Individuals Admitted to Hospital with COVID-19, Retrospective Cohort Study. This looked at 47,780 individuals, 55% of them men with a mean age of 65 years. In this paper, most of the study participants had pre-existing illnesses such as heart disease, diabetes. I would like to focus on the following questions. There is a statement in your paper that says, Most studies so far have focused on symptoms associated with post-COVID syndrome rather than organ dysfunction. Why do you think that is? And why is it important to focus on organ dysfunction?
I think the reason that they focused on symptoms was because that's the easiest thing to do to start with. So that's the starting point. And we've got to remember that even though it seems to people who have suffered with long COVID, I've got family members and friends and colleagues who are in that bracket, but still the rate of discovery, the speed with which we're finding things out is quicker than usual. So the reason that they were looking at symptoms first is because the easiest type of research is a survey where you ask people what they've been suffering with. And then after that, the next step is to organize for scans or blood investigations or other ways of looking at the function of the organs. And so that needs a more detailed research study to be set up. And you need a large sample size in the population to be able to make conclusions about that. So in our study, we used data from the Office for National Statistics. So, I've worked with colleagues there throughout the pandemic and been able to use the data riches, if you like, of the UK to try and get answers quickly. And in this case, because we have good coding in electronic health records, we could look at the impact on acute or chronic organ problems following COVID infection.
You showed that there were increased rates of multi-organ dysfunction of individuals that had contracted COVID-19 following discharge. In your opinion, what is going on in the body to cause multi-organ dysfunction, and what does this mean?
Yeah, this is a very tricky question, which we don't have the answer for yet. There are many theories, hypotheses of what the underlying so-called pathology might be. What's the mechanism? It's likely that, given the variety of symptoms and the clusters of symptoms that people have, and the different patterns of organ impairment, that we're not looking at just one disease. It's likely that this is a so-called syndrome where people have different subtypes, but even that we can't define well yet. That's why our study is funded, to try and get at that. You know, there are some people who complain more of cardiopulmonary, so that means heart and lungs. So they're complaining more of breathlessness, chest pain, those kind of symptoms. There are people who have more cognitive or neurological symptoms, such as brain fog, which is the term in common parlance to describe the lack of concentration, the fuzziness in the head that people have been describing. Others are describing more systemic symptoms like fever, just general malaise, feeling unwell, tiredness, and so on. So we need to know much more about those particular symptoms and symptom groups, because they're likely to be related to some form of organ impairment. There's another study that I've been involved in called the CoverScan study, where we did multi-organ MRI scans in people to look at different organs. And there's a suggestion there that at 6 months and now 12 months, there are a subset of people who have persistent organ damage. And we need to study that more. We need to know whether there's an impact of the findings on the scan. The reason it's important is because if it wasn't there before people got COVID, then that's another reason to, first of all, influence policymakers that getting COVID, living with COVID, as the Prime Minister says, is not a benign undertaking. And if you know, whether it's heart or liver or lungs or kidneys, if there's some impact of that, then people should be aware of that.
You and your team, which I think this is the paper you just mentioned, wrote a second paper, once again published in the BMJ in March 2021, which I thought was leading edge at the time. It's entitled Multi-Organ Impairment in Low-Risk Individuals with Post-COVID-19 Syndrome, a prospective community-based study. Your team's report in this paper utilised a small study group of just over 200 mostly previously healthy white women and showed that 25% of this group had significant heart damage after COVID-19, which was prescient at the time. New research released by a team in the US last week seemed to indicate that even a mild case of COVID-19 can increase the risk of cardiovascular or heart problems 1 year after diagnosis. This US study had a much larger sample size over a longer period of time, looking at over 150,000 mostly white males. As a cardiologist, what do you think is the international significance of these two findings for all women and men? Have there been any studies on healthy young people of colour who are infected with SARS-CoV-2? And would you anticipate the results being different?
So I think the reason, first of all, why we've got studies in the US and the UK is what I alluded to before, is that both of these countries have had an ideology and an approach since the beginning that infection suppression, by that I mean keeping the infection rate down over time, is not something that we wanted to pursue. As a result, those two countries will, by definition, have longer term consequences, more long COVID in this case. You don't find this being such a problem in New Zealand or Taiwan or Japan. But that's because of infection rate. I don't think that I anticipate differences by ethnicity, other than, if anything, I would expect more impact in people of colour or people of ethnic minority, because what we've seen with the acute effects is that people were more likely to be admitted to hospital, more likely to be admitted to intensive care, more likely to be at risk of dying if they were of, for example, South Asian or Black descent. And the reasons for that are many. It's least likely to do with a biologic cause or a genetic cause. It's much more likely to do with exposure to the virus. So much higher proportions of people from ethnic minorities have been in frontline roles during the pandemic, from porters, cleaners, nurses, healthcare assistants, taxi drivers, and so on. There's studies that I've been involved in with the Office of National Statistics around overcrowding in housing and so on. So it's likely that people from these populations may have had increased exposure to viral load. And so we haven't seen it yet, but I would expect there to be a large effect in ethnic minority populations. One of the things we're looking at in our study is at the referral rates to long COVID clinics around the UK, where what I said is what I'd expect, but we haven't seen those people coming forward yet. Is it that there genuinely is less long COVID, or is it because they're not being reached by the services that are being offered? Those are two different issues which need different solutions. So we're looking at that in our study and Stimulate ICP.
And thank you so much for re-emphasising the link between allowing unfettered transmission of the virus through the population and the risks of long COVID and multi-organ damage. I think that so much needs to be highlighted, particularly in light of Boris Johnson's announcements of releasing all COVID public health measures. Your study looked at people with an average age of 45 years that had suffered from COVID-19 pre-vaccination. In just under 5 months after having COVID-19, you discovered that over 70% of these people had impairment in one or more organs. You were looking at the heart, lungs, kidneys, liver, spleen, and pancreas. This was in a group relatively young and fit with a limited history on the whole of past illness. This study was done in the UK between the 1st of April and the 14th of September 2020, pre-vaccination. Do you expect the figures for organ damage to be lower post-vaccination?
It's a great question. I think that we expect yes. There's no trials of this, but there's what we call observational data. So looking at large data sets like from the Office for National Statistics to compare vaccinated with unvaccinated, and it appears that people who've been vaccinated and had all of their doses seem to have lower rates or less severe long COVID, which is good news, of course. There's been anecdotal reports of some people with long COVID after their vaccination feeling like their symptoms transiently got worse. But for the most part, people seem to report that it's got better or stayed the same. And vaccination, as it's been trialled, the evidence that we have is to reduce the risk of a severe acute bout of COVID-19. It's reduced risk of hospital admission and so on. So to answer your question, yes, I would expect that. But even with a milder variant such as Omicron, where we know that the severity has been less in terms of hospital admission and so on, the high rates of infection may lead to still many thousands of people with long COVID developing regardless. So we have to monitor the situation. I mean, it would be obviously a huge breakthrough and tremendous to say that vaccination minimizes or greatly reduces long COVID, but without monitoring it in the future, we can't say that for certain. And of course, we need to know what the next variant of concern is and what the impact of that is.
Another important finding from this research was that COVID-19 is affecting other pre-existing illnesses, such as diabetes or heart disease. I assume the virus is attacking the body, exacerbating these illnesses. Understandably, people were also hesitant to go to the doctor during peak lockdown pandemic times, which would compound the problem even more, ultimately resulting in worse outcomes and potentially dying. This is a massive new health burden on top of an already stretched system that will affect healthcare organisations globally. How do you think this will impact healthcare systems in developed countries? And how will this impact the less developed countries with very little healthcare infrastructure?
The easy answer for me is hugely. I think that there's been this false rhetoric that backlogs in the UK for non-COVID care, such as cancer and cardiovascular disease, have been because of lockdown or restrictions, but actually we've, as well as the impact of COVID, which you just highlighted there, which can lead to chronic conditions, we've filled so much of the focus of the health system on the acute effects of COVID that we're not able to deal with pre-existing conditions as much as we would like. And we've got that compounded by potentially new disease, new diabetes, new kidney disease, new heart disease. So we have to be very careful as individuals and as populations and as a health system that we don't create a stick to beat our own backs, because there are finite resources. we've got finite number of health professionals, finite number of hospital beds, finite numbers of clinic appointments, and we need people to be healthy in order to live fulfilling lives, but also to be able to do the jobs that keep our economies working. And so, whether it's long COVID because of the symptoms, long COVID because of new diabetes, there are people who are off sick in different sectors because of those things. So much more monitoring and planning is required, but avoiding the infection in the first place is still the best way, still the only way that's proven to avoid long COVID.
Thank you. We just talked about what is described in the medical community as a syndemic. Can you please share with the audience your definition of syndemic, including the socio-economic impacts as it relates to this coronavirus?
I believe the term syndemic was coined in the 90s, actually, but I only came across it in relation to coronavirus. Syndemic is the term used to describe that an infectious disease isn't just caused by infectious agents, such as in this case, coronavirus. It's also capitalizing on the so-called social determinants of health, poverty, lack of education, lack of health literacy, digital divides, geographic inequality. It's also the interaction with underlying conditions, cardiovascular disease, which is my specialty, wearing my clinical hat, diabetes, people who are on immunosuppressive medication for their underlying conditions such as cancer. All of these have not only been linked to the acute risk of severe COVID, but may also have an impact on the longer term. So all of that interplay and complex interaction of non-communicable disease, the risk factors, and with the infectious disease is what people call the syndemic.
Thank you. In view of your findings, should we be testing and assessing every working age young person, including children, for post-COVID syndrome if they have been infected with SARS-CoV-2, i.e. have a positive COVID test, even if they don't have symptoms of long COVID?
I don't think we have evidence to do, for example, detailed scans or a whole battery of blood tests in everybody. Firstly, that would lead to a lot of burden on doing the test, but also in our studies we found that most people thankfully don't have abnormalities, but definitely in people with symptoms, I think we have to look to rule out other underlying conditions and then look to see if there's any progression of disease. And then in people who are maybe more vulnerable, have had say hospitalized COVID and been admitted, they probably need to be followed up in the first instance. But in practical terms, I don't think even a health system like ours, that with the NHS, has the capacity to do what you're proposing in everybody.
After all this kind of doom and gloom with long COVID, do you believe there could be a cure for long COVID? And how does this tie in with the trial that you're about to start, looking for possible drug treatments for long COVID?
So I don't think, first of all, this is doom and gloom. I think it is that we know what we can do and what we could do, and there are active decisions being made not to do it. And so each of us has the option even now to try and reduce infection risk. And when you compare with other countries, we do see that. Yes, I do, to answer your question, believe that we're moving closer every day to understanding the mechanism, whether it's in terms of the immune pathways, whether it's to do with inflammation, and whether it's to do with changes in the body, such as microclots. Now, in our study, one of the parts is this trial that I mentioned. We're testing 3 drugs to start with, but it's a platform trial where, like the so-called recovery trial, other drugs can be added as hypotheses emerge. But one of the drugs that we're testing is colchicine, which is an anti-inflammatory. Another drug is rivaroxaban, which is anti-clotting. So if there are microclots, then we'd hope that that improves people's symptoms. And finally, a combination of antihistamines, famotidine and loratadine, because some people have described a so-called mast cell activation response, and this antihistamine combination would reduce that. And if these drugs work, then that tells us something about the pathways. If it doesn't work, then you can cross that box off and we can keep looking. But the scale of the effort, in countries around the world that's now funded to do this research, means that I think we will, at the very least, get better at treating it, if not finding cures for it.
Thank you. And just to enlighten the audience, a mast cell is a type of white cell involved in kind of your allergic or hypersensitivity response in the body. So the sheer numbers of people affected and potentially affected by long COVID is mind-blowing. What steps are being taken to facilitate a community-based approach to the care for long COVID sufferers as it relates to training, education and funding for community medicine and caregivers?
That's a wonderful point for me. So I'm not sure I have all the answers. In our study, we set out at the outset to do what's called integrated care. So you don't want a cardiologist sitting in his box and the dermatologist or the gastroenterologist sitting in his or her box. We want the primary care and secondary care and the rehabilitation experts to be in a pathway with the patient in the middle, where we're all joined up. So that actually is happening already in the case of long COVID, and we're testing the effect of doing it even more integrated by the way we're doing investigations. I think also, given the resource implications that you said, we have to have online adjuncts. So in our case, we're using a digital rehabilitation platform, because if each person was to have, regular, let's say, monthly physiotherapy appointments face to face, we haven't got that many physiotherapists, even with our current population of long COVID, to provide that service in the NHS or even in private healthcare. So we have to find new ways of doing that. And then there's something about the prevention that we're talking about, trying to treat and prevent underlying conditions. That's community-based, looking after your physical, mental health in the community. Some of those things are as relevant to long COVID as any other chronic condition.
Thank you. We've run out of time, unfortunately. I could go on for another hour interviewing you, and I really hope that we can revisit this interview, because you're doing some fascinating research that I think needs to be promoted and to the audience at large. But thank you so much for taking part in this interview today. Your contributions are wonderful. As I say to a lot of the clinicians I'm interviewing, thank you for everything that you do and for your dedication and focus to the sufferers of long COVID. This was a really enjoyable and very informative interview, Ami.
Thank you very much for me.
Okay, bye-bye.
All the best.
Thanks for listening to this week's episode of COVID-19 The Answers. If you enjoyed the episode, please subscribe, rate and review, and do visit our website kajalamedical.com /COVID-19 The Answers.